and everybody was able to access. So you see what I'm doing. I'm putting all the drawings and all the videos there, so that should be available to you. Okay, let's start with labeling just a few things here, and hopefully you're starting to recognize my drawings. What kind of section is this that I'm looking at? Any thoughts? Frontal. Yeah, it's going to be a frontal section. So that's going to be, this is your cortex or your cortical region, right? This is going to be your cerebellum. Okay, the topmost portion of the brain stem. Quick review. Anybody?
Midbrain.
Yeah, awesome. Midbrain. Middlemost areas, pons. And then the bottom, medulla. And then we have the spinal cord down here. Okay. And at the bottom of the spinal cord, we have a whole bunch of nerves that kind of stick out here on the bottom. Does anybody remember what those are called from anatomy? Did you cover those? Brachial plexus? No, not the brachial plexus.
Roots.
Sorry, no, not the sacral plexus. At the very bottom of the spinal cord, there's some fringy. Cauda equina. Yeah, that's going to be your cauda equina. And these are just the nerves as they exit the bottom of the spinal cord. What? Okay, well, good. Okay, this is your cauda equina. Cauda equina literally just means horse's tail. Okay, that's your cauda equina. And it's nothing more than all those nerves that exit the bottom of the spinal cord. Okay, we'll talk about what happens in a minute. So just above the cauda equina, so you can see how the spinal cord comes down here and then it tapers to a point right in this region here. That very tip of the spinal cord has a special name. Does anybody know what that's called? Did I look at Gio? Don't want to put anybody on the spot. That's called your conus medullaris. Okay, it's a special part of the spinal cord. We'll talk about that. So conus medullaris, medullaris. So that's your conus medullaris. And that word means nothing more than the tapering of the very bottom of the spinal cord as it traverses through the vertebral bodies. Okay. So having said that, does anyone know what vertebral level the very bottom of the conus medullaris ends at? You heard this before in anatomy?
C1.
No, C1 would be way up here, right? C1's way up here.
Oh, sorry.
L2, right. That's going to be L2, right. The very bottom is going to be L2. So the spinal cord proper ends at the vertebral level of L2. Okay, so what happens is all these nerves that are coming off are the residual from everything kind of is compressed here in the conus medullaris, and then the spinal nerves are coming off. And that's a really important point. We're going to talk about why that's important later today. But the very bottom of the spinal cord only goes to the L2 vertebral level. Okay? All right. Now, that's it about the spinal cord in general. Now what I'd like to do is talk about the different meninges. The first meningeal layer is going to be very tightly adherent to the nervous system itself, okay, to the CNS. So I'm going to represent this color in green, and it'll be consistent throughout the rest of the talk. So if I have, it's tightly adherent, so I'm going to just draw it very closely associated with the CNS. So it comes in here, okay, goes all the way around. I'm just trying to represent that this very first layer, this very first meningeal layer, is very tightly associated CNS. Okay, so it goes all the way around it. It's contiguous with the cortical region, through the cerebellum, and all the way through the spinal cord. Okay, does everybody see that? That's my very first meningeal layer. Does anyone know what the very first meningeal layer is called, by chance? That's your pia matter, P-I-A. P-I-A. You see that? Matter is M-A-T-E-R. Pia matter. What's coming through? Yeah, P-I-A. I mean, think about the word itself, pia matter. Start with the word matter. Does anyone know what that means? Mother, correct. This is pia matter, so it's a mother. And the word pia, does anyone know what that means? It's going to be soft. So pia matter is going to be a soft mother. Okay. And that sort of makes sense when you think about it. Since it's very tightly associated with the CNS, it's going to provide a nice soft cushiony layer all around the nervous system, all around your central nervous system. That's your first meningeal layer. There's your pia matter. And then moving on to the next meningeal layer, we're going to have, I'm going to draw it as a space. There's actually going to be a physical space between the pia matter and this next meningeal layer. So I'm going to draw it as having a little bit of a space here. See that? And again, it goes everywhere the pia matter goes, but there's a space between this particular meningeal layer and the pia matter. This color for me is kind of a maroon, and I'll keep it consistent as we go through. Does anyone know what that second layer is called? Somebody said arachnoid matter. That is correct. So let's go ahead and write it up here. So arachnoid, A-R-A-C-H-N-O-I-D, matter, M-A-T-E-R. And again, matter is going to be your mother. The second layer is arachnoid, and that's going to be a, yeah, that's your spider. Spider mother. Okay, so you have your pia matter, most closely associated with CNS. And then on top of that, you have your arachnoid matter. And it's called arachnoid matter because it has these projections. And these projections actually help maintain the physical space between the arachnoid matter and the pia matter. I'm just going to represent them like this, just lines all the way across. Okay, they have a special name. I'll talk about that in a minute. But you should be very much aware that arachnoid matter has a space underneath of it. And this space is maintained by these projections. Okay, so general all the way around. So you have your arachnoid matter, you have your pia matter first, and then you have your arachnoid matter. And your arachnoid matter is called so because it has these projections that stick out. And these projections have a special name. If I point to them here, they're called trabeculae. So T-R-A-B-E-C-U-L-A-E. Trabeculae. And trabeculae are nothing more than special projections that help create or maintain the space between the arachnoid matter and the pia matter. So I'm going to say that they help maintain space. And the space that is created or maintained by these trabeculae has a special name. Does anybody know? Any thoughts?
Arachnoid space.
The subarachnoid space. They help maintain the space, and that space is called the sub, because it's below the arachnoid matter. So space is equal to the subarachnoid space. Can anyone tell me what's in the subarachnoid space?
Small spiders.
CSF! Awesome, Jeff! Yes! In this space exists CSF, which stands for cerebrospinal fluid. We'll talk more about CSF as time goes on, but you should know that the subarachnoid space is filled with CSF. Anything else in there? Maybe what we talked about on Wednesday is going to also be your cerebral arteries. Cerebral arteries and veins. Okay, so in general, all of your cerebral arteries, all those arteries that we talked about, you know, your ACA, your MCA, your PCA, everybody that we talked about is going to be located in the subarachnoid space. Kind of important. So in the subarachnoid space, you have a nice watery cushion of CSF, and then floating around in the CSF in the subarachnoid space are your arteries and veins, which supply your brain with blood. Okay, got it? All right, that's 2. Moving on to the third level, the third meninge. Now, this meninge, there's really not a lot of space between the arachnoid and this last layer. And this last layer, I'm just going to represent in blue. There are really 2 different layers, but in this first big overview picture, we're just going to look at it, both of those as one individual thing. Okay, so for me, it's going to be this blue. So there's no real physical space. There's potential to be physical space. So there's a potential space. So in case blood wants to pool in that area, that could be a problem. But for the most part, it's not super adherent to the subarachnoid or to the arachnoid matter. Okay, and all it does, this last meningeal layer, it's actually a hard outer covering. And when we pull the brains on Wednesday, you're going to see it. It's like a plastic layer almost. Kind of reminds me almost, you know that membrane in crab? If you ever eat crab and it has this like plastic stuff to it, it's kind of like that. It's a dense connective tissue. Okay, so there's the third layer, or the outermost layer, is called your dura matter, D-U-R-A. Everyone know what dura stands for? Yes? Strong or tough? Yes, strong or tough mother. That's a tough mother. And that's mostly for protection. Okay, good. So pretty basic stuff. There's only one more thing that I'm going to add and I'd like to talk about, and we're going to go and zoom in on detail, but there's some areas that are kind of special. Does anybody remember what this fissure is called that separates, or that it's a big groove between the left and right? Yeah, good. That's your longitudinal fissure. Okay. talked about that one before, so I'm not going to go into much detail, but that's just going to be a big groove between your left and right hemispheres. And you should know that the dura mater actually comes down into this longitudinal fissure. And it creates a tough separation between the two of them. And that invagination or extension of the dura mater here, right here into the longitudinal fissure, is known as your fall cerebri. So F-A-U-X. F-A-U-X. Cerebri. And that's nothing more than the extension of the dura mater into the longitudinal fissure. This is something you will definitely see on Wednesday. It's called your fall cerebri. It's that tough, like plastic coating that kind of goes in between the left and the right hemisphere. Does that make sense? Yeah? Okay, and there's another fissure that we haven't really talked about yet. We haven't had the opportunity. There's a fissure that exists here. So the dura mater extends into this fissure. First, let's label the fissure. There's a fissure right here. The fissure that exists is between the cerebellum and the cortical region. Does everybody see that big indent right there? So this fissure, it's a very large fissure. It's called your transverse fissure. Okay, and your transverse fissure is nothing more than that big space between your cortical region and your cerebellum. Does anybody remember the name of the other fissure that we talked about first class, I guess? Anybody? Lateral, yeah, the lateral fissure. And that's going to be the big old groove between the temporal lobe and the parietal and frontal lobes, right? So think about the thumb of the boxing glove. And why I like to mention the transverse fissure now is the dura mater also invaginates into this fissure. And there's a hard covering that's created. And this is going to be one of those things that you have to be careful of when you pull the brains. It kind of keeps the cerebellum tethered behind when you try and pull the cortical region out. And again, this fissure, not fissure, but this extension of the dura mater has a specific name, and it's called your tentorium cerebelli. So you have your fall cerebri and your tentorium cerebelli. Tentorium cerebelli is nothing more than the extension of the dura mater into that transverse fissure. This will be very visible on Wednesday. Yes?
If these serve as like anchor points, I'm sorry if you said it already.
Sorry, anchor points?
Like for the dura mater, like why it push through the layers?
Why does it go? So yeah, it's just a tough connection. Actually, all of them go through, and you'll see more detail later. This is just the way I'm representing it in the first beginning piece. This is like a big overview. And pretty much every time I talk to you about a new topic, we'll start out real broad, and then we're going to zoom in. Questions? Do you have?
Just a really quick one. For the dura mater going into the longitudinal, is it Faux or Faux? Like an L or U?
F-A-U-X. I think it's F-A-U-X. You can Google that if you want, because I'm a terrible speller, but I'm pretty sure it's FAU, F-A-U-X. Any other questions? Okay, so what I'm going to do is I'm going to zoom in now. So this is the big picture overview. I'm going to zoom in here to this region right here. We're gonna blow that up. One more thing. So I said that the very bottom of the spinal cord goes to the L2. Does anyone know what the very bottom of the dura mater extends to? So it's going to be that place where you put your second goniometer when you're testing lumbar flexion and extension and lateral. S2, yes, this is S2. So this point right here is at the level of S2. Yes, absolutely, thank you. It takes a while to respond. There you go. So the very bottom of the dura mater actually extends to S2. So the point is showing you that is that there's quite a bit of space between the end of the spinal cord proper and the very end of the dura mater. We'll talk about that at the end or on Wednesday. I'm not sure when. Questions? Yes, Sam.
Just to clarify
Yep.
what you said before, so the cauda equina, that's just branches of nerves. So when we get down to like those lumbosacral plexus, it's already off of the spinal cord.
Mm-hmm. So yeah, so each of these, okay, the best way to say it is if the spinal cord proper ends at L2 vertebral level, okay? So if it didn't like get narrowed down and all crunched up to fit to L2, it would extend all the way down. So this is like a real crunched up area of the spinal cord, and these are all the nerves that are extending, all the peripheral nerves that are coming from those segments that are all kind of compressed. And it's called a cauda equina. It's a horse's tail. And you'll see it. Well, no, we won't see it here. But yeah, it's literally just a whole bunch of nerves that come down together, and they're going to exit through their correct vertebral level. But the spinal cord proper ends way up high. Does that make sense? Anybody else? Question about that? Okay. Let's go ahead and move on to the next one. And like I said, we're going to zoom in, bless you, to this region right here. We're just going to look at the cranial meninges. I'll try and keep my colors. Come on. Keep going. Okay, this one is titled Cranial Meninges, and what you see here is my representation of this. This here is a frontal section through, this would be your skull. Okay. So that's going to be my skull, and then we're going to draw the cranial meninges in this empty space here. But down here, let's go ahead and say that this is so if you have a cross section and it's coming through me, if I'm looking at this, let's make this this side. So this would be the right cerebral hemisphere, and then this would be the left cerebral hemisphere. So let's see if that turns out right. Yeah, so this is going to be my right cerebral hemisphere, and then this would be my left. And then this is representative of that outer cortical layer on the brain. Yes? Ben.
So does that make this posterior?
I'm just trying to draw it so that you can see it. So if you were looking at me and you did a frontal section, backwards, yeah, it would be backwards. Yeah, either way you want to look at it. If you want to make that one left, that makes more sense to you. It doesn't really matter one side versus the other. I was trying to make it so that this was the right side, but when I look at it, it's backwards compared to what you see. Does that make sense to everybody? So I'm just saying that this is one cerebral hemisphere, and then this is the other cerebral hemisphere. You have left and right leg backwards, it's fine. Any other questions? Kind of one of the things, it's sort of shaded a little bit gray here. Why do I have the outer layer of the cortex shaded gray? Gray matter, yeah, good. And what's gray matter? Sorry, say that again? Neuronal cell bodies, right. That's going to be your neuronal cell bodies. Good. I like that point. All right, let's start. And as I said before, this is going to be a little bit different as far as the dura mater is concerned. The dura mater, you should know that the first layer of dura mater is tightly, there's two layers for dura mater, okay? The first layer is going to be really tightly adhered to the skull. I'm just going to put it here, okay? And that dura mater is going to be particularly tightly adhered to the sutures of the skull. Does everybody know what the sutures are? That's when the bones grow together and they fuse together, they create suture lines. So I'm just going to represent these as the suture lines here. Okay, and that periosteal, whoops, said a word that I didn't mean to yet. This is going to be your first layer of dura mater that's very tightly adhered to the skull, and that's called your periosteal, P-E-R-I-O-S-T-E-A-L. That's going to be your periosteal dura layer. Okay? So it's not only tightly adhered to the skull proper, it's also very tightly adhered to these sutures in the skull. Okay, first layer of dura. And right underneath the periosteal dura layer, we have another layer of dura. Just make it this color. That is just another layer of dura. It's directly underneath the periosteal layer, but it's its own separate, unique layer. And it's here, and it actually makes a little invagination. It goes down, and then comes back up. Okay, so by making that invagination, it created a space. Okay, it's going to be this little invagination, this second layer of dura that actually comes down and creates this extension of dura into the longitudinal fissure that we talked about before. All right, one step at a time. The second layer of dura mater is known as your meningeal dura. M-E-N-I-N-G-E-A-L. Okay, so dura itself is just composed of two different layers. The periosteal layer, tightly adhered to the sutures of the skull. Underneath of that layer, there's the meningeal dura. The meningeal dura actually isn't completely contiguous with the periosteal layer in the area of the longitudinal fissure. It creates a space right there. Does anybody know what's in that space? It's a special kind of sinus. Yeah, that's your superior sagittal sinus. Superior sagittal sinus is nothing more, and I'm going to represent that these are, I'm going to call them endothelial cells, which are just the thing that lines the outside, the outside of the veins themselves are made of endothelial cells. And you may actually see this when you pull off the brain out. In this space is this thing called your superior sagittal sinus. Okay, superior sagittal sinus is nothing more than a large vein venous collection system. So all the other veins are, and also some of the CSF is going to end up getting dumped in the superior sagittal sinus, and it's a large vein that exists in this physical space between the periosteal and dura, specifically in the area of the longitudinal fissure. It goes all the way front to back. Okay, and it's going to be a large venous collecting system, very large sinus. So we got that? And these just represent the endothelial cells that line the outside of the veins. Sometimes when you pull the brain and you look through the skull, you can see some red, and that's indicative of the outside of that sagittal sinus. Questions? Yes.
Is the periosteal dura the dark blue, or is it the space between the black and the blue?
The periosteal dura is this color blue right here. It's this. So the osteal layer, tightly adhered to bone. So it's the one that's closest to the skull. Very tightly adhered to that skull. So think osteal, periosteal, around the ostium, very close to it. That's periosteal. Directly under that, in this other blue color I've indicated here, this is going to be your meningeal dura. That's that more like an aqua color. And again, we have the extension going down here with the dura mater, and that's going to be your fossa cerebri. So that's what that actually looks like. I think it was LA who was asking, why does the dura invaginate? Well, they all kind of invaginate. It's just the way I'm trying to portray it. We'll see that in a minute. So I see where we are. Next layer. What's the next layer underneath the dura? Yeah, arachnoid. Here's your spider mother, right? So this is going to be right here. And this is normal. These are all just a blown up region, a blown up view of all your cranial meninges that are just normal at this point. Okay, so there's your arachnoid matter underneath your dura, directly underneath your meningeal dura. Okay, and I said that arachnoid matter had some extensions coming off of it, some projections. What is the name of those? Does anybody remember? Yeah, those are trabeculae. Good. So I'm just going to represent them like this, kind of like before. These are just projections that help maintain that physical space. So those are my trabeculae. So let's label all this stuff. So this is my arachnoid matter with the characteristic trabeculae. And the trabeculae help maintain that subarachnoid space in which is free-floating your cerebral veins and arteries, as well as it is filled with CSF. We'll talk about that as we go through. Okay, completing the picture, we have the soft mother here, very tightly adhered to the brain itself, as you can see. Okay, so the green layer is going to be your soft mother, and that's going to be your pia matter. And all I've done is I've blown everything up and did a close-up view of the big picture, specifically in the area of the cranium, okay, only in the area of the skull. And as I said, floating around in the CSF in the subarachnoid space, and I'll represent it here. It's just a red circle. Okay, that's nothing more than one of your cerebral arteries. Can be anyone. Just say cerebral artery. Okay, just represented here in the subarachnoid space. I have my cerebral arteries, and then usually paired with the artery, I have another, let's see how I'm going to do this. I'm going to have cerebral veins. So my cerebral veins are going to be here. Okay. Label that up here. That's your cerebral vein. Okay, so your cerebral arteries and your cerebral veins are in that subarachnoid space, and they're well supported by the trabeculae. And as I said previously, they actually empty into this superior sagittal sinus. So what you have is a series of things that are called bridging veins. So I'm going to draw that here as a bridge. little bridge to that superior sagittal sinus. Okay, so you have your cerebral vein. Here is the circle, but there's a connection, a venous connection from the cerebral vein into the superior sagittal sinus that's called a bridging vein, B-R-I-D-G-I-N-G vein. And the purpose of the bridging vein is nothing more than to just connect all the venous circulation with that superior sagittal sinus to help with drainage. Kelsey, is there a question?
I'm good, I'm just,
Huh? Yeah?
I'm good.
You're good? Okay. If you couldn't read something, I can write it out.
No,
But
I'm good.
okay.
When I swim.
Okay. Did you have a question, Ellie?
Yeah, so the trabeculae, are they like helping keep the brain stable? Because I understand the brain just moves a little bit just as we kind of move around and
No,
stuff.
they actually maintain that space to fill up with CSF and to help support the cerebral arteries and veins. That's what that space is for.
Okay, so they're kind of like suspensory ligaments for the vessels?
They're not ligaments. It's a dense
like,
connective
yeah.
tissue. Yeah,
I
it's
guess
more of a.
functionally as a comparison.
I don't know. So I would say that they just help maintain a small enough space so that you can see. And when we pull the brains, you're actually going to see this layer that's the arachnoid matter, and then directly underneath of that, you're going to visually see the arteries and veins underneath the arachnoid matter, but you can't see the trabeculae, right? They're helping to create that space. Okay. Any other questions? Does that make sense to everybody? You see what I'm doing? So, one of the important things to know about these bridging veins is that the cerebral veins are connected to the superior sagittal sinus, and the sinus goes all the way in the middle. So these bridging veins come across and up. Okay, so everything's coming this way. And that's going to be important when we talk about the subarachnoid hemorrhage. Okay, let's go ahead and move on. I got it all. The next is going to be your epidural versus subdural hematoma. Overall, two very different patient presentations, and this is something that you will see. We'll see somebody this summer, I guarantee you, with an epidural or subdural hematoma. It's very, very common. Because you're going to be in acute care or skilled nursing or home health setting, and this is classic. What I'm going to choose to do is, again, these are just representative of skulls. These are frontal sections through the skull. And there's just two of them. So to differentiate from one from the other, I'm just going to put a dashed line down the middle. Okay. And then over here, I'm going to represent the epidural hematoma, and over here, I'll represent the subdural hematoma. We got it? All right. And like I said before, the skull has sutures. So I'm going to draw these sutures in over here. They're going to be more important for the epidural. I'm going to start out here on the epidural hematoma side. Okay. And very tightly adhered to the skull, especially to those suture lines. What was that first meningeal layer? Periosteal dura. Good. So I'm going to start over here, and what's going to happen is this dura is still here, very tightly adhered to the skull, and I'm only going to draw it to this point here, because that's a suture line. And I'm going to say that this poor individual got a hit on the head. He took a real hard hit right here. He maybe had a fall, maybe bumped into something. I'm not really sure. But because of that fall, some blood started to pool just under the skull, and that caused the blood to pool into a hematoma. And since this is an epidural hematoma, it's above that periosteal dura layer. And this is going to be your epidural hematoma right there. Okay, does everybody see what happened? Let me label a little bit more. So this is going to be your periosteal dura. No, this should be an A. And I'm talking about an epidural hematoma. So in this hematoma presentation, the blood is going to pool above the dura mater, epi. Okay, epidural. And so the cause of an epidural hematoma is going to be a trauma. And I said hit to the head. Okay, when there's a hit to the head, there's a fine network of arteries that resides just under the skull. Right? And those are your meningeal arteries. Okay, so what the real cause, it's caused by trauma, but in response to that trauma, you get a rupture of meningeal arteries. And that's why the blood pools above the dura mater. Okay, so what happens, let's see, what color am I? This color. So underneath the, you can see the periosteal dura layer has a big old hematoma right here. Underneath the periosteal layer, you still have your meningeal layer, meningeal dura layer. That's going to be associated. And you're also going to have your arachnoid matter underneath that. It's also going to be misshapen on this side. And then what happens with the brain, pia matter is tightly adhered to the brain. On this side, the brain's going to look relatively normal. You're going to have all those nice sulci and gyri, right, like I indicated before. That's relatively normal. But this side, everything gets kind of compressed, so you're going to have some problems, right? And that's your pia matter. There's your trabeculae. They're still there. Everybody see what happened? So everything's there, but the side of the epidural hematoma is severely compressed. Okay, let's talk about the cause. Is going to be hit to the head, causes a rupture of the middle meningeal arteries. If you want to say meningeal arteries, that's fine. The signs and symptoms of an epidural hematoma are very unique. Okay, that person, after hitting their head, they might present with a headache, because they hit their head pretty hard. But then there's going to be a period where they're perfectly normal. Okay, they're walking around without any problems whatsoever. And this time between the bump on the head to when they start demonstrating problems has a special name. It's called a lucid interval, L-U-C-I-D interval. And during the lucid interval, that patient, oh yeah, I hit my head, but everything's fine. I'm perfectly normal. I'm not demonstrating any signs and symptoms. Okay, but then over the course of time, they're going to become non-responsive and possibly in a coma. What actually happens is the meningeal arteries are teeny tiny little arteries, and you're getting arterial blood flow that's building up, but it takes a while for it to build up and cause that increased pressure. Okay, and then over time you get enough blood that causes the hematoma, then the patient has the symptoms, and it's pretty dramatic. So they hit their head and they're fine for the most part, but then they start having problems. Okay, and the treatment for this is actually something called burr holes, burrholes. And with burr holes, so how do you think they'd identify the blood pooling or the hematoma? Anybody know anything about imaging? CAT scan, yeah, CT scan. Okay, a CT scan is really going to be good for picking up blood pooling, especially. And once they identify the very specific pattern, because it's caught there between two sutures of the skull, looks like a half tennis ball, right? They actually go in and they just drill. They drill a couple of holes and evacuate the blood from that area. What you see as a physical therapist after the person has had the hematoma evacuated is they have just a little suture, a couple of little sutures, but nothing to be worried about, right? They've got a couple of, but the bulk of their cranium is still there. You might see a couple little sutures, but no issues with just a burr hole treatment. Okay, that's the most common for the epidural. Questions? Okay, let's take a 10-minute break.